Hello, the goal of this video is to discuss what happens when therapy ends up being harmful. I know that for many people and in many instances, therapy can be a really positive, life-changing experience. Um, and a lot of that is because therapy is a really unique environment where patients kind of go in and share a lot of information about themselves that they typically wouldn't necessarily share to others. And often are very trusting of the therapist. They're going in assuming to some degree that the therapist will or has the potential to help them. And usually there's an assumption that the therapist probably isn't going to try and hurt them. And I think that unique environment is what makes it possible for people to, in many cases, heal effectively or develop sort of coping strategies for their life. But it also means that it's in some ways a very delicate environment. And if if the therapist, sorry, takes advantage of it in certain ways, whether intentional or non-intentional, it can end up really harming the patient. So over the past year, I've actually spent quite a bit of time reading stories of therapy harm and therapy abuse. And while each person is unique and each situation is unique, and there's, broad variety of different ways in which harm can occur, um, there are some common themes that emerged, and that's what this video is really dedicated towards. And then at the very end, I'll discuss some neurodiversity specific considerations, just because this is a neurodiversity focused channel. So the first common theme that emerged was that in many of the stories I read, whatever blurring of boundaries it was that happened in therapy, or whatever kind of unusual or harmful event occurred, in many cases, it had a really deep and overwhelming impact on the patient. And in some cases, that was accompanied by sort of a loss of control or a feeling of the patient that they were kind of unable to make decisions in a way that they typically would. So that could mean that they found it very difficult to impossible to say no to a therapist, or that they ended up just being consumed by the stressors of the therapy relationship. So more specifically, for some patients, this might mean that their life gradually started to revolve around making their therapist happy or appeasing their therapist. In some cases, patients ended up over time hearing more and more about their therapist's life and potentially developing a social relationship or other types of engagement with their therapist. And in many cases, these patients ended up feeling like it was their responsibility to fix things in their therapist's life or to make things better. And they ended up spending a lot of time between sessions thinking about that. Some people even ended up describing like a feeling as if they were living from session to session. So instead of feeling like therapy was a place where they could bring concerns from their life, therapy ended up almost being something that took over their life and was really draining that energy in between sessions. Another example, which actually is not therapy specific, but I think it's still worth noting because it involves a somewhat similar power imbalance. There was a college student who had a professor engage with her sexually, and she was really deeply hurt by the power imbalance there and the aftermath of that. And while I couldn't find the exact article where I first read about this, the quotation really stuck with me. It said something to the effect of, she felt like while this relationship was happening, everything was happening in her mind from the professor's perspective. She essentially felt so diminished as a person. Her own perspective felt so diminished that her full focus was really on the perspective and feelings and thoughts of the person who had power over her in this situation. Um, so how else can this sort of loss of control or feeling of being overwhelmed appear? I think it can extend to maybe less frequently discussed or potentially more common areas of therapy harm. So while sexual abuse certainly does happen in therapy, fortunately, it's not something that is, well, it's far too common. Um, but it's still fortunately a minority of um, therapy instances where sexual abuse is something that would happen. Much more commonly, therapists might end up sort of practicing outside of their scope, or having dismissive reactions. So something I've heard of quite frequently from autistic friends is that they might go to therapy, and tell their therapist that, that they are autistic, or that they really think that they're autistic, hoping to get support for that. Um, and in some cases, the therapist will be supportive, which is great. That's the ideal reaction. Unfortunately, in other cases, the therapist might become very dismissive of the possibility that the person's autistic. In some cases, the therapist might directly say that it's not possible for the person to be autistic, or might question them a lot whenever they bring up that they think they are autistic. Um, and well, each person is going to react to this differently. In many cases, this can end up taking up a decent amount of energy. Someone might find that their thoughts about therapy, if they do think about therapy, that it might be trying to figure out how to convince their therapist that they really are autistic, what more justification they need to provide to get their therapist to take them seriously. So, even in an instance where, therapy harm may not be devastating someone's life in general, it can still take up a lot of energy within the scope that it's occurring, if that makes sense. And just to give a final example under this category, if a patient ends up providing, professional or other practical favors for their therapist, they might end up overextending themselves there as well because of the power imbalance. So, for example, if a patient is an IT specialist and a therapist needs IT support, they really ideally wouldn't be asking a patient for that kind of help. But if they were to do so, the patient might end up sort of dropping everything and prioritizing their therapist's request, or doing what they can to fix their therapist's computer, even if it ends up taking an excessive amount of time. And I kind of wanted to pause here because I'm imagining that if someone has had, very healthy, boundaried therapy relationships so far, that's fantastic. That's really great. But they might also wonder, like, wow, this sounds a little bit dramatic. I don't think that if my therapist asked me for a favor that I would automatically feel like I have to drop everything and do that immediately. And that is great if that's the case. I think what often happens in these examples is that there can be a buildup of these things over time, much like with any kind of um, unhealthy relationship pattern. Someone isn't necessarily going to walk into their first therapy session and the therapist will immediately ask them for a large favor, or immediately disclose, great deal of information about their life. These things tend to start, fairly small and then increase over time. And sometimes the patients who are most vulnerable to this type of relational pattern in therapy are people who have had previous instances of victimization that are related. So for example, if someone has frequently been yelled at throughout their life, if their therapist were to start yelling at them, they might find it really hard to speak up against that, because that's what they've potentially been taught to tolerate in the way that others treat them. And so that kind of comes into the second point, which is difficulty trusting others and a limited sense of self-worth. So, by design, therapy is really meant to be a safe environment for a patient. Not a perfect environment. I don't think anyone can or should be expected to be a completely perfect or safe bubble, and that wouldn't necessarily be realistic. But it is meant to be a place where someone can expect a certain amount of predictability, where they can expect that the time that they spend in therapy will be focused primarily on things that are important to them. So if there's something bothering them, if they're struggling with their mental health in a certain area, that the therapist will, will care and will talk with them about that. And if someone has been mistreated or abused by others in their life, they might seek therapy specifically so that they can have an environment where they don't necessarily have to worry whether they can trust the other person. Therapy is meant to be a place where you can assume, the therapist is there as a professional. They're not there to, create a sort of messy dynamic with you. And so, you can feel relatively at ease. But if even this kind of safe bubble of therapy ends up being hurtful or difficult, then how is the patient supposed to easily trust people or situations in the future? So that is sort of the rationale that I see most often when reading about therapy exploitation or therapy harm. And I think it's a really good explanation of how that how the phenomenon of difficulty with trust can come about in patients who've experienced therapy harm. Personally, I think that there can also be two sort of related aspects as well. So I think one possible extension of this is that very complicated or unhealthy therapy dynamics can sometimes really skew a patient's perspective of relationships in general. In the sense that, for example, if a patient were to occasionally meet their therapist for coffee, just as sort of a social meeting, but the therapist says that this is part of therapy and it's for the patient's benefit, the patient might start to wonder, oh, okay, if I meet people for coffee, apparently that's for my own benefit. It's not a mutually beneficial social thing. And that's a little bit of a contrived or artificial example, but it might make the patient start to feel like they're not doing enough in their friendships. Like if therapy feels like a friendship, but it's actually therapy, then what is a real friendship? Is it something where the patient is purely giving to the other person and there's not much reciprocity? To use a little bit of an analogy outside of therapy, sometimes for people who were parentified in general, so growing up, if they were sort of given a lot of responsibility by their parents, or if they often felt responsible for their parents' emotions, it can be hard to sort of drop that sense of excessive responsibility even going into adulthood. So I think another extension of this is that patients might begin to almost commodify themselves. For example, if someone felt that their therapist really only valued them or accepted them if they, if they were happy, or if they were productive, if they were doing favors of some sort, if they were offering something socially, financially, or sexually, they might start to think that those are the only aspects of themselves that are acceptable, or the only aspects of themselves that they have to offer others. And that can be very challenging because it means that the person likely may be struggling with some amount of shame. So to give a concrete example, if someone experienced financial abuse from their therapist, or the therapist was charging them more, or asking for, financial donations or something similar, they might feel like they need to pay for others in their friend group in order for people to spend time with them, or they need to be offering people, gifts or financial favors. If someone felt that their therapist only liked them when they were providing resources or productivity or some kind of professional favor, they might find it really hard, even after that therapy relationship has ended, to to scale back and to not be working all the time. They might find themselves using work constantly as a distraction or as a way that they could feel useful. Even if that's not their only motive for working, it could make them take it to potentially a unhealthy level. And likewise with any other area as well. So if a patient were to experience sexual abuse in therapy, they might start to wonder if others are valuing them purely for sex. And in some cases, and I'll put the reference below, well, it certainly varies from person to person, people who have experienced sexual abuse in therapy may seek out sexual experiences where they do feel like they have some amount of control over what's happening. A third potential theme that has emerged in reading about therapy harm is just a sense of guilt and isolation that many people struggle with. I imagine, although I haven't actually found this in reading, but I imagine that one potential reason for guilt is that there can just be such a strong expectation that people go to therapy to get better, that if you are going to therapy and you're not finding it helpful, even if you're not finding it actively harmful, I feel like there's almost a little bit of stigma about that. But even beyond that, I think that patients who are struggling with therapy in some way often find it to be a messy or confusing process. They're not necessarily only feeling one thing. They might feel attached to their therapist. They might feel grateful to their therapist in some ways, and they might feel frustrated or confused at the same time. And as one resource says, and I'm paraphrasing this here, therapists who are to the point where they are engaging in a pretty broad pattern of harmful behavior with a patient might struggle to acknowledge it directly. They might instead say that the patient was just being difficult or was acting out or was being manipulative. And in some cases, unfortunately, a therapist might just claim that something didn't happen at all unless the patient is able to prove it. And I think that can be especially tricky for sometimes more subtle forms of therapy harm, things that might just be spoken to a patient in session, but there's no official record of it that the patient can go back to. Another thing that can sometimes happen is that a therapist might tell a patient that, yes, this was unusual, but I did it as an exception or a special favor to help you. And then patients might feel guilt for not finding it helpful or for being hurt by something that was a special favor to them. Especially if you keep in mind that these patterns often do happen within a framework of a patient being quite attached to a therapist or feeling a sort of power imbalance where it's hard for them to disagree with or say no to a therapist. One key part of that power imbalance is that therapists are often assumed to be pretty objective. And so as such, they're assumed to have a certain amount of insight into what a patient's intentions might be. So, if a therapist were to say to a patient that something is meant for their good, or that something the patient said was manipulative or incorrect or fill in the blank, the patient might really wonder if it's true and might assume that the problem is them, or that they didn't communicate well enough, or that they are overreacting to something. And unfortunately, I think that can sometimes create an environment where patients are going to be really hesitant to speak up if they feel like something is off. In some cases, therapists can also either directly put pressure on patients not to tell anyone. There have been instances where therapists have just directly asked patients not to tell others what was happening in therapy. What seems to be a little bit more common is that therapists might indirectly put that pressure or sort of guilt trip the patient. They might say, okay, if you were to, you could report me if you wanted to. But then, this would happen and it would impact me and it would impact, my family or my coworkers or others in this way. Some therapists might say that their life would fall apart if the patient were to tell anyone. And this can create a challenge for patients, of course, because in many cases, patients might not know how accurate this is. You know, if they do tell someone, does it really mean that all of these people's lives are going to fall apart? If a patient does believe that, that's an immense pressure to put on the person. Even just, you know, the risk of a therapist potentially losing their license is something that can be a lot of stress for a patient who really cares about that therapist. And sometimes can make the patient afraid to find or to share what's happening even with a new therapist or psychiatrist because they might be worried about potential ramifications. There are, you know, sometimes ways where patients can explain what's going on and still maintain a level of control over what happens, but patients might not necessarily know that ahead of time. I think one other thing that can sometimes happen that can fuel this feeling of guilt is the ambivalence or feeling of internal conflict that many patients feel. Patients might wonder, you know, for example, for patients who have experienced sexual abuse from their therapist, they might wonder if they were to have ever asked for that or have ever felt attracted to their therapist in some way. Doesn't mean that it was their fault. Doesn't mean that, you know, their case is an exception and it wasn't actually abusive. Or, you know, I imagine that if a patient, you know, offered to do a couple of favors for their therapist and then ended up doing a lot more than they anticipated, they might feel sort of confused about what is their responsibility, you know, if any. In some cases, especially if a patient is still currently seeing that therapist, they might be worried that if they voice concerns, the therapist will take away part of the therapy or will penalize them in some way. So I've read stories where patients were worried that if they expressed concerns that their therapist would go from, you know, being very casual, having sort of a oversized role in their life, to withdrawing and becoming, you know, extremely clinical and very cold. And in some cases, they did feel like they were punished by their therapist with that very abrupt switch if they brought up concerns. So that can certainly be challenging as well. You know, my personal perspective and one that I think is echoed in a lot of these therapy abuse resources is that there are certain things that patients just can't consent to in therapy, even if in a situation outside of therapy, it would be very normal. For example, a sexual relationship between two adults within therapy, patients just can't really consent to that after all. I think even things like self-disclosure, to some extent, I think it is, and it does become a complicated and nuanced topic because to some extent, I think that patients can provide input on whether they benefit, for example, from a therapist being a very blank slate who discloses very, very little about themselves to a therapist who might disclose a little bit more about their perspective and approach and who they are. But there is a level of self-disclosure, I think, especially if a therapist is going into quite a bit of detail about, you know, active situations in their life or ongoing situations or concerns. Or certainly, you know, if a therapist were to divulge personal information about other patients, certain types of disclosure patients just probably also cannot consent to. And, you know, likewise, things like financial abuse or a variety of other, you know, unfortunately, I think there's such a myriad number of ways that therapy harm can happen that it's not possible to address all of them. But I hope that those who are struggling with feelings of concern or confusion can find resources that are helpful for them. So the last point that I want to touch on is, what does any of this have to do with neurodivergence and autism in particular? You know, sort of the overarching broader point here is that autistic individuals are often vulnerable to a variety of different types of victimization and misunderstandings. You know, most environments, including most clinical or therapy therapeutic centers are not tailored towards autistic individuals. And so we might have a higher rate of misunderstandings or miscommunications in therapy. And if a therapeutic relationship were to become, deeply confusing or hurtful, it might be harder to get help for that. And I imagine that someone might be more likely to second guess themselves a lot, especially if they've had a lot of confusing social interactions throughout their life. But the real reason I wanted to bring up this point is because there can be a little bit of a paradox between wanting to, ensure that there are firm boundaries in place that provide safety and stability for patients, but also wanting to make sure that there's a certain amount of flexibility. I think that for marginalized individuals in general and autistic individuals in particular, sometimes it can be helpful if therapists are a little bit more flexible. If if you're someone who is autistic or has an intellectual disability or another developmental disability, and you've gone through life feeling like a lot of people are treating you like something to be fixed, or a lot of people are treating you as if they're your therapist, even when they're not. It can be refreshing if a clinician takes a little bit more of a human approach. If they're willing to explain their perspective on autism. For some patients, talking about special interests can be really important and really helpful. And so if a clinician, engages in that a little bit, that can be more helpful than someone who's sitting there like a complete blank slate, without making any kind of disclosure about themselves at all. So how can clinicians tell whether they're engaging in, healthy flexibility, or whether boundaries are, going from being flexible to being just broken or absent in a way that's not helpful to their patient? I don't think that there's a unique, perfect answer. And I honestly imagine that being a therapist is a really complicated job, because you're probably trying your best with a lot of different factors, and in hindsight, you might realize that something should have been done differently. But I think there are 3 metrics that can be used to, hopefully prevent really major harm from being done, and hopefully help positive things happen instead. So one is, are things changing over time in kind of a continuous or escalating manner? So it's one thing if a therapist decides that a patient benefits from a little bit more self-disclosure. And assuming that's also something that the patient has expressed interest in. It's another thing if that just keeps increasing over time and increasing, and it goes from, the therapist may be sharing a little bit about their hobbies or their ideology, to the therapist sharing, maybe a little bit more about their daily life and some minor stressors here and there, to the therapist sharing, pretty specific details about challenges or, very personal aspects of their life. And everyone's definitions for each of these levels might be a little bit different. So that's why the second point can be really important, which is being transparent, both with your patient, but also with, with a supervisor, if you have one, and being open to getting feedback from others, like a supervisor. Obviously not encouraging people to share their patients' private details with random people. But getting feedback from your patient as well can be really important. I think if for whatever reason you're in a situation where you feel like it's too complicated to explain to people, or you're kind of afraid what the feedback will be, or you feel like the feedback is too difficult or it's too negative, that's probably a red flag. Like that probably means that supervision or consultation is all the more important. And the third element of this is just proactivity with all of this. I think, waiting to the point where something becomes really confusing is generally not the best practice for addressing it. So instead, asking people from the beginning what kind of approach is helpful, asking regularly, even if there doesn't seem to be a problem at all, um, you know, what could be changed, what's going well, what isn't going well. That can be useful information, and it can also help identify any situation where a patient might be starting to develop some kind of conflicting emotion in some ways. Um, and I think the fourth element is just ensuring that there's some amount of boundaries that are non-negotiable. So again, I think that within reason, patients can maybe provide input on the level of self-disclosure. But if a patient wants to know absolutely everything about your life, maybe that's time to step back and instead of sharing everything about your life, or not literally everything, but sharing quite a bit about your life, maybe stepping back and figuring out why the patient wants to know that, and maybe what would be another outlet for that. Or I mean, as you can tell, I'm not a therapist. This is just a potential example. And likewise for other areas as well. If a patient were to, I'm just trying to come up with another example here. If a patient were to try and give you gifts, if I think turning away a small gesture of appreciation from a patient can be hurtful. It might be best to just be flexible in that situation. But if the patient is giving, increasingly valuable gifts over time, or trying to give extra money or something of that nature, certainly that's probably where it's time to step back as well. So this is a little bit of a ramble, but I hope it was helpful to at least someone. Thank you very much for watching, and take good care.